Perfect. All right. Hello, everyone, and welcome to our second webinar as part of our MCNIG Career Series. We really welcome all the participants in joining us today, as well as our lovely guest speakers who have taken time out of their day to share some wisdom with us. So today's webinar will focus on high-risk birthing and our part 1 series of labor and delivery. Next month in July, we will be focusing on low-risk birthing or community settings. So I will just briefly introduce each of our guest speakers, and they will kind of go into a little bit detail about their history and their roles. And after that, I will open up the conversation to all of the participants to be able to ask any questions for a Q&A session. You can direct your questions in the chat box and I will read them out for you. Or if you'd like to unmute yourself, just raise your hand and I'll call on you to ask your question in person. So for everyone's awareness, we are recording this session. It will be posted on our MCNIG website, which is mcnig.ca. So you can find it there and rewatch it if there's anything you wanted to go over, or share that with your friends and colleagues. I just ask everyone to kindly mute themselves throughout the webinar unless you are called upon later on to ask your question. Okay, so we will begin. To start, we have 4 lovely labor and delivery nurses all with quite different experiences, and very exciting to speak about it today. First, we have Melina Carreri, and we have Chelsea Miller, Marley Galina, and Brooke Brimmer. So I'll just have each of them introduce themselves with a few questions. And Melina, you can start ahead.
All right. Hi, everyone. I'm Melina. I am a nurse at Mount Sinai Hospital, which is in downtown Toronto. I went to school at Ryerson. I graduated in 2013. And then my job at L&D at Sinai was my first job ever. And when I started, we had a new grad program, actually, where we did a rotation between L&D, postpartum, and our antepartum high-risk unit. So I was a part of that program, and I had no previous experience when I first started. And I actually consolidated in long-term care. So I really didn't have a lot of even bedside experience when I started. So the new grad program was really great for me because I really got to learn pretty much everything about being not just an L&D nurse, but just like the basics of being a nurse. And the team at Sinai was incredible in teaching me all of that. And I guess I've been there for about 8 years. And in the last little bit, I focused a lot of my time in one of our programs that's called the Ontario Fetal Center, or the OFC. So that is basically a program that helps to improve quality of life and outcomes for babies that have Spina Bifida or congenital diaphragmatic hernias or twin-to-twin transfusion syndrome. So there's a few fetal procedures that we do. And that's kind of been where I've focused a lot of my time in the last little bit, and where I've become a lot more passionate about. But I also still do low-risk births and other high-risk pregnancy births and taking care of moms that come to Sinai. And yeah, and I chose L&D. I chose L&D, to be honest, on kind of a whim. I didn't really know where I wanted to be because I didn't have a lot of experience. But I applied everywhere I could. And I basically thought that it would be a good fit for kind of my personality, but I didn't really know. So it was a bit of a risk, but it was a risk that totally paid off for me. And I absolutely loved it. It totally fits my vibe, and I'm super passionate about it now. So I'm grateful that I took that chance. So I think that that would be my advice for new grads and new nurses. I would say nursing school can be really scary, and it can be really overwhelming, but try to take as many experiences as you can because it's a safe environment where you have a preceptor and you have someone that you can ask lots of questions to. So I would say to just work really hard and really try to get as many experiences as you can, and then just apply, try new things, take chances, and see where you'll fit, because there's so much opportunity in nursing. And even if at the beginning you might not feel like super passionate about where you are, you can always change your route. You can always try new things. New programs might come up. So I would say that would be my advice, to just take chances, keep on going, work hard, and don't be afraid when you don't have experience. Because if you're a hard worker, that will be acknowledged, and you can really learn just about anything. So as long as you're passionate about caring for people and being a good colleague and a good coworker and a good team member, you can excel in basically anywhere that you are and find where you're passionate about.
Amazing. Thank you so much, Melina. Next, we'll have Chelsea.
Hey, hi everyone. My name's Chelsea. Interesting to follow Melina because I, have a similar path to Melina actually. I'm a registered nurse at Mount Sinai in the High-Risk Obstetrics L&D there, and I actually graduated from U of T in 2014 from their nursing program. And I also went into the new grad program, I guess about 1 year after Melina, or maybe 6 months after Melina started. But my new grad program was direct entry to L&D. So I also had no experience in nursing. And I started off in L&D really like knowing not much. But my consolidation was in pediatric ICU at Sick Kids. And I also had a labor and delivery placement in the acute care rotation during school. So I had a little bit of, information about it prior to starting my new grad position. I didn't get to do postpartum and antenatal like Melina. I did direct entry to L&D. So I spent about 4 months training in L&D. So it's very, very L&D specific, my training. And then after that, I was kind of working on my own by the 5th month. And that was all sponsored by the Ontario New Grad Initiative. I believe it's a little bit different now. I'm not sure if they're actually doing the new grad program, but I felt really well supported during my time transitioning to practice as a new nurse. And so I guess that was about 7 years ago. And as I've been in labor and delivery, working with low risk patients and high risk patients, I think what's interesting about Sinai is you have a lot of opportunities to learn different things, and going into high risk obstetrical nursing kind of allows you to do a little bit more on the medical surgical learning side. So you learn about lots of different high risk conditions for patients who are also pregnant. So taking care of patients who have serious cardiac conditions, patients who have endocrine disorders, patients who are having a very preterm birth, those kind of things. So that's kind of what I really enjoyed. After working there for about 1.5 years, I started learning more about the high risk clients. I also really enjoy working in L&D because every day is a little bit different. You get to work in the operating room. You get to work, you can work with a low risk patient, unmedicated birth. You can work with a patient who's having a high risk birth. And most recently, in the last 3 years, I've also transitioned to the team leader role. So that's the charge nurse role, working in L&D and just basically taking on a more of a leadership role and coordinating things that are happening in the unit. And I also like being able to work in the triage department too. It's kind of like a little mini emerge where you basically see all the pregnant people and decide who needs to come into the unit and what kind of treatment they need. So I've really enjoyed all of the various roles that I've had working at Sinai L&D. In addition to that, about 5 years ago, I started teaching for U of T as a clinical instructor. So I've had now 5 years of teaching with second year students, and most recently this past year, 3 rotations of first year students. And I'm personally very passionate about teaching. I really enjoy taking on new hires. I enjoy working with the consolidation students. And so I wanted to kind of delve a little further into the teaching role. So I've done some TA work, I've done some clinical coordinating work, and I've done the clinical instructor role, and that's kind of become a passion for me. And I know that some people who go into nursing later in their career find the education role very fulfilling. So I've really enjoyed working with the students. I think when I was a nursing student, I found that my clinical instructors, the ones that were really supportive and really great, really shaped like how I felt about nursing and going into nursing. So this is just my way of kind of giving back to future students and people who have become my colleagues, because I know I have like 7 students that I've taught who now work with me at Mount Sinai in L&D. So I really get to see the full circle, and that's a really enjoyable experience for me. Why I chose L&D. L&D is such a happy place to work. It can be very sad, but it's sad less of the time. And so I really enjoy just feeling happy at work and getting to be there for that really amazing moment where people are bringing a person into their family. And that just like warms my heart. And I think that's the best part of my job. And then a sentiment of advice. Okay, so I say this to every nursing student prior to like leaving the clinical. You have to love what you do, because nursing is really like a work of your heart. If you don't love what you do, change where you're working. Wherever you go into, like Melina said, you're going to be successful. Wherever you go, you're going to learn. You don't have to be afraid. People will help you. But if you don't love it, change the direction. Don't stay anywhere for too long. Nursing is great because there's so many opportunities. And if you're not feeling passionate about it, it's a lot of hard work and a lot of your life to dedicate to nursing. So just make sure you're checking in with yourself, because burnout is real. And that's my advice.
Perfect. Thank you so much, Chelsea. And I just wanted to give a brief overview, and not that this was meant to be a Sinai takeover. Luckily, we do have Marley from McMaster here, but some of our guest speakers from Sunnybrook were unable to join us last minute today. So this is the reason we have a majority Sinai panel right now. But next we have Marley, who we are very excited to hear from a different perspective and a different tertiary care center.
Hi, everybody. Like was just said, I'm Marley. I work at McMaster, which is in Hamilton. It's also a level 3, so high-risk labor and delivery unit. My journey to get to nursing was a little bit different than some people who've spoken so far. So I started out taking midwifery, actually, in university. So I did that for 2 years, and I think that's really what started. Sorry, we just moved, and my dog is not used to living in this condo yet. So I started out in midwifery, and that's what really kind of sparked my love for working with families and birth. But it just wasn't the right fit for me. The lifestyle was a bit too much. So again, that's when I kind of felt like nursing might be the right choice for me. And I wasn't sure if I wanted to end up in labor and delivery, but I just liked the amount of choice that I had with nursing, and it opened up a lot more doors than simply midwifery did. So then I did nursing, accelerated program at McMaster, and then, sorry guys. And then I did my first 4th year placement on a hematology unit, and I kind of felt like that might be an area that I wanted to get into, but more specifically had a passion for pediatrics as well. So that was like pediatrics, hematology, oncology was one thing that I thought I might want to pursue in the future. And then I did my final consolidation placement actually at McMaster in labor and delivery. And that, again, just reignited my love and passion for birth and working with families that I had from midwifery. So upon graduation, I kind of had 2 thoughts of what I wanted to do. I feel like I always knew I wanted to pursue labor and delivery, but again, with nursing, I didn't want to. I felt like once I ended up in labor and delivery, that's where I was going to be for the rest of my career. So I wanted to explore kind of the pediatric side of things before I went back to L&D. So I accepted a new grad position at Sick Kids and worked on their oncology unit for about a year. I liked it, but the work was super sad. And again, I mean, similar to labor and delivery, we got to know the families really well and be there at important times in their life, but definitely was a little bit too emotionally draining for me. So I went back, I applied and got accepted at L&D at Mac, and I've been there ever since. So I guess we're coming up on 2.5 years or so that I've been there. Yeah, and definitely was the right fit. I'm glad that I kind of did some different type of nursing before I got back to L&D, but I'm very, very happy and love what I'm doing now. Unlike the two speakers before me, I didn't have a new grad, so my orientation on labor and delivery was a little bit shorter. I had about 20 preceptored shifts and then was off on my own, just starting mostly with low risk births and then getting introduced to some higher risk patients as we went along. I'm now doing like scrub and scrub circulating in the OR, just started triage training as well. So those are some exciting new opportunities that I've got to have in the last couple of months. I also just had my first consolidation student, which was quite lovely. Education, again, is something I'd like to explore a bit more in the future once I get more comfortable in my role that I'm in at labor and delivery. But similar to what Chelsea said, it's definitely become a bit more of a passion of mine. Why I chose labor and delivery nursing, like I said, when I kind of got a taste of midwifery, I knew it was something that really resonated with me. Just the opportunity to work with families in such an amazing time in their lives is something that I feel very blessed to be a part of and I appreciate a lot. Obviously, we have those sad times in working labor and delivery, but again, it's still such a privilege to be a part of all of these moments with families. And I think that's what I love most about the job that I do is just, I don't know, there's nothing compared to it. It's just a wonderful moment. I always say my favorite moment of shift is when you look over at the dad, partner, whoever it is, when the baby's born. It's just still gets me, still makes me emotional, even after 2 years. So I love it. My one piece of advice, again, I kind of have to just echo what was said before me. Nursing is so vast and you have so many different opportunities. So find what you love and keep doing it because it is difficult, especially like we've probably experienced in the past year. If you don't love it, it's just going to be draining. You're going to get burnt out and you're not going to be able to provide the care that you want to your patients. So whether in the future it is labor and delivery, that's awesome. But if you get there and you know what, it's not quite the right fit, even within maternal child nursing itself, there is so many different avenues you can go down. So just keep learning and keep exploring and you'll find the right fit for yourself.
Wonderful. Thank you so much, Marley. And lastly, we have Brooke.
Hi everyone, my name is Brooke. I am currently a clinical practice leader in the birthing unit at Humber River Hospital and then also an RN at Mount Sinai in labor and delivery, where I work casually now since my current job is kind of a Monday to Friday job. So I'm still able to pick up some shifts on the weekend at Mount Sinai, which is wonderful. I did my final consolidation at Mount Sinai and started working there right after graduation. So since day one, I've always kept my job at Sinai. And just echoing kind of what Melina and Chelsea say, there's something really special about, that place. We have a lot of world firsts that happen there, a lot of unprecedented high risk patients there. And it's really amazing the way the multidisciplinary team can come together to handle everything, especially a lot of the emergencies that we have. And the fact that it's also the largest birthing center in Canada with close to like 7,500 births a year is pretty amazing. There's babies everywhere all the time. So if you love labor and delivery, working in a high risk center is definitely the way to get the volume and the deliveries. You will have at least 20. We have every 24 hours there at minimum. So I always knew I wanted to work in maternal child healthcare. So eventually I wanted to get a little bit of pediatric experience as well, similar to Marley. So I worked in a pediatrician's office while I was still full-time at Sinai. And then I thought I wanted a bit more. So I went to a pediatric inpatient unit at Humber River for a year. And then that also wasn't quite getting it for me. I'm a bit of an adrenaline junkie. So I finally ventured over to Sick Kids Hospital in the emergency department, where I worked for the last 3 years prior to taking on this new leadership role. So I think personally, like I said, I really thrive in that fast-paced environment. So I've always kind of had two jobs or two areas of nursing going at the same time. And I really enjoyed the more high-risk cases and the more emergent situations that would come through the doors in emergency. And then most recently, I ventured into travel nursing in Northern Canada, where I worked 2 one-month stints so far in Yellowknife, Northwest Territories, in the obstetrics unit there. So this has been by far my favorite nursing experience to date. The position when you work up there kind of involves working triage, labor and delivery and postpartum kind of all at once, all at the same time, kind of you're all over the place. There's no physician on site at the hospital, so you have to be kind of really confident in your skills and ability to manage whatever might walk through the doors. And there's often only one or two obstetrics trained nurses on at a time. So you have that other person you can rely on, but sometimes it might be someone who's only a postpartum trained nurse. So you really get to use all of your skills and challenge yourself to be able to handle anything. As well, being immersed in a new culture whereby there's a lot of Indigenous women and families who are flown in to deliver in Yellowknife or who reside in Yellowknife as their main address. So we get all of the deliveries from the west side of Nunavut and a large portion of the Northwest Territories. So it's given me a whole new appreciation for learning new cultural realms and hearing about our Canadian history firsthand from these patients. And the way that different women are able to labor and birth and go through that process is really, really inspiring to me. Up north, there's a lot less intervention. So we have a lot less use of oxytocin, a lot less epidurals, and a lot less C-sections. So it's a lot of natural birth, a lot of labor support. And that experience is what really solidified that I wanted to commit my career as an advanced practice nurse. And made me kind of fall in love with obstetrics all over again, because you're so truly connected to that patient when, you know, it's just you and them and you don't really have a whole lot else around. And that was really inspiring to me to kind of dive back into labor and delivery after doing pediatrics for a few years as well. I graduated from Queen's University in their 4-year nursing program in 2016, and then I started my master's of nursing at Ryerson in 2019. I kind of enrolled in my master's to take the caring and change making to a whole new level. And I actually have 2 weeks left in my master's, so almost done. But that just goes to show you, like, if you're a nursing student right now, you can always take your education further, or if you're thinking about taking your master's, it's very possible to do it while you're still working. So I was always working full time and I never found it too overwhelming. So I've kind of had a bit of an experience of, you know, tertiary care nursing and obstetrics community care here at Humber, and then also remote care, which has been really great. And my current job as a clinical practice leader kind of involves wearing 3 hats, which has been very challenging. You have the role of an educator where you have all the new staff that you need to train. You have ongoing education for all the nurses you have on the unit. Then you have the policy and best practices hat where you need to create and update new policies and procedures and flow on the unit. And then also a bit of a role of a clinical nurse specialist in a way, because I do create care plans for some of our high-risk patients where either mom or baby is high risk. So I find that it's an area where I'm constantly learning, and that's what high-risk obstetrics offers for you. Is there's so many crazy things that can happen. And even if you've worked in this area for 20 years, there's always going to be something new or something challenging. And that's really what I love about it. Why I chose labor and delivery, because overall, kind of what everybody said, it's such a special area. You never know what's going to walk through those doors. It is a little bit like emergency department in a way, and being a part of someone's special day and having the time to build that bond is so incredible, and they will honestly never forget you. It is hard, it is tiring, it is physically and emotionally draining at times, but it's also so amazing, so exciting, so uplifting, and honestly just very inspiring what women are able to do, especially with your support there. And I love the unpredictability of it and the fact that there's so much room to grow. So like everyone has also mentioned, you know, you start as a new grad, you get trained to the operating room, which is really unique to labor and delivery nursing, because otherwise you would have to be an OR nurse to work in the OR. Then you get high risk trained, then you get triage trained, then you can be a charge nurse, and then you can, you know, the opportunities are endless in high risk obstetrics, which is really great. One sentiment of advice for the audience. So for RNs looking to switch areas, my advice would be, don't be afraid to take the leap and try something new or step outside your comfort zone. Having experience in multiple areas or expertise is only going to make you a stronger nurse and open up more opportunities for you. And if you feel yourself, you know, feeling burnt out or not wanting to go to work, this is a clue that it's time for you to try something new and to challenge yourself. I think that having the diverse experience and moving around is so valuable. There are so many options, not just tertiary care where many of us work, but there's also community care and remote nursing, and they all have something so different and so special to offer. So don't be complacent and always continue challenging yourself. And then for new grads, follow your gut for what you're passionate about. When I was at Queen's in my 4th year, I was told you're never going to get a nursing job in labor and delivery. You're never going to get a consolidation placement at Mount Sinai. Your school's in Kingston. They're going to take only Toronto students. And I didn't let that stop me from putting my top choice as, you know, labor and delivery and high risk. But in fact, if you don't end up getting that placement, it doesn't mean you can't work in that area. You can take other courses to help prepare you to work well in that area. So by taking like your neonatal resuscitation program, fetal health surveillance, or your OB certificate course, eventually, if this area is truly your passion and you feel it in your heart that that's where you want to work, you will find your way back into it. And just because you've worked in medicine or surgery or any other unit, even emerge, you can always come back to work in high-risk obstetrics. Yeah, that's all.
Amazing. Thank you so much, Brooke. That kind of touched upon one of the questions that the participant asked, which was what types of courses and certifications would you recommend to do after graduating? So anyone can answer that, so feel free.
Yeah, I think the ones I just mentioned, obviously in my role right now, that's what I have to tell the new nurses to do. And we interview a lot of staff. So if we see that you have neonatal resuscitation, that is a really, really big one. If you have fetal health surveillance, that's also key, because looking at the fetal health surveillance strip is kind of the bread and butter of obstetrics nursing, and you have to be able to really excel at being able to interpret that. And then there is the OB certificate offered through, I don't know which college it is. In Toronto, I know we have it, but there are other schools that offer.
George Brown.
George Brown, yeah. So you could do that, but that's taking it kind of above and beyond. Even if you just start out with those other two, NRP and fetal health surveillance, I think those are kind of the two main certificates that you need.
Great. Some other things, supplementary kind of courses that people can take, just even to better prepare themselves or really understand this type of nursing and what kind of care goes into it, and really seeing is that a good fit for you, includes also the breastfeeding course on the RNAO website. Yeah, so that's one of them. But a lot of places, I believe, are looking at seeing if you do have these extra certifications, because that will add to how likely you'll get an interview, or they'll look upon your resume as a little bit further ahead than others. But again, as echoing what Brooke said, definitely if you have any kind of nursing experience, starting out even in an NRT, a nursing resource team, in a medicine floor, even in long-term care, all of these skills, it just really depends on how you can translate that during your interview or in your resume, because all of the skills that you learn anywhere else are completely applicable to this obstetrical or perinatal nursing. So really just being able to use what you know and how to apply it appropriately to whatever opportunity you're looking at, I think is really key and helpful. Another question from Anasma. She asked what the difference of duties between a midwife and a L&D nurse are.
Okay, I'll answer that one. So midwives in Ontario, they can only care for low risk clients, whereas L&D nurses, we can care across the spectrum from low risk to high risk. That being said, even though I work in a tertiary center, so McMaster, we do have midwives that work out of there as well, doing low risk births. Their scope of practice can include epidurals. They can run oxytocin inductions if they get orders from the MD. So they can do a lot of things, but that scope of practice is also dependent on where they work in the province. So some places don't allow midwives to care for patients with inductions or epidurals. It just kind of depends where they're working out of. But the midwives that we work with in Hamilton, they can do those things. And then if there are things that fall out of their scope of practice, or the patient becomes high risk or is needing.
Oh, Marley, I think you're frozen. Oh, there we go.
Oh, sorry, did you hear any of that? Or was it muted the whole time?
Nope, just up until you were talking about some places don't allow midwives to privileges?
Yes, so it depends, where you work where midwives work in the province, kind of what they can do within their scope of practice that they're approved for. But in most places now they can do epidurals, they can run oxytocin and do those sorts of things. The midwives that we work with here in Hamilton, they can have patients with epidural or running oxytocin. But if the birth became high risk or the patient needed a C-section, they would have to consult with the OB that's working, and then there would be a transfer of care and nursing would take over. So every once in a while, we do have patients that get transferred to us if they need a C-section or other high-risk sort of scenarios. For example, if someone came in laboring and they were preterm. So we still get to work pretty closely with them, which is lovely because they are masters of low-risk birth and you can learn a lot from them.
Perfect. Marley, a specific question for you from Amy. How many deliveries does your hospital do per year?
So we just had a huge increase in the last couple of months, but we do about 4,000 births or so a year. But I think the last couple of months we've done over 400. So we're having a big issue with the amount of space we have and the amount of patients we're seeing. So just even in the last couple of weeks, we've had some backups with our postpartum beds and not a lot of flow. So we're seeing like we can't bring in our scheduled inductions because we have nowhere to put them. Our scheduled C-sections are getting pushed by hours. So we're doing, like, management has been doing a lot of different things to try and manage our flow a bit better. But I think we're just really outgrowing the unit here that we have in Hamilton. So we'll see what happens in the next couple of years, but still doing less than Sinai, but we definitely are doing more births than we have in the past.
That's awesome. And just to clarify, at Sinai, we have an high-risk antenatal unit, we have our labor and delivery unit, and we have our postpartum unit. Is that the same at MAC?
Yeah, sorry. Yeah. So we have labor and delivery in our triage unit. Labor and delivery, we have 8 birthing beds and 2 ORs. And then we have an antenatal unit and a postpartum unit as well.
Perfect. Okay, next question from Sarah. I am interested in L&D, but am not a new grad. Are there opportunities for longer orientation for nurses that have worked in other fields?
I can answer this one, and then anyone can add on as well. I find that nurses who have worked in other fields actually are such great additions to the team. I think you have so much to offer just having had nursing experience in another area. And I often find that nurses who have worked somewhere else, they seem to need less orientation because you already have the basic nursing skills and you have like that nursing knowledge of being able to tell, when I'm really concerned about this patient or not. And that's something that a new grad has to build. But generally, the orientation for any nurse that's making the transition to labor and delivery is usually about 16 to 20 shifts with a full-time line when you're in orientation. And then, of course, I can speak from just 3 different hospitals' perspectives, but there's always room for more time if needed. And I think one other thing is you're never going to feel fully ready, especially in an area like labor and delivery, which is considered a critical care area, because there's so many different things that you could possibly see that you might not see them all during your orientation period, but it is such a great team area that you always have that support. And 16 to 20 shifts is quite a lot. It's a lot more than you would get on most units. I know most medicine surgery units, when I went to Emerge, it was only 12 shifts, for example.
And I just want to add, am I unmuted? Yeah, to that as well. So coming from not having experience at all, like I did do the new grad, which was a lot of extra time, but at the same time, once you're on your own, you build relationships with your colleagues. So there were so many times that I was asking, one of my colleagues, hey, can you come look at this bleeding with me? Can you come look at this tracing with me? I'm not sure what to do. And you're always bouncing ideas off each other. So I would say while you're training, it's good to start building those relationships, because then when you're on your own, you don't feel like you're totally on your own. You feel like you have people there to help you out. And yeah, L&D is so can be so all over the place and so unexpected, and you have to think on your feet, but you have to know that your team backs you up. So I think that's like super important, and it's totally possible. Even without new grad, you can learn what you need to learn. You can keep going forward, learn the basics, focus on them, and you can do really well. Because if I can do it, anybody can do it.
Melina, don't sell yourself short. I think I just want to add one more thing. Like, I think, like Melina said, it's a team effort. And I think when anyone comes in from a specialty, like we've had a couple of people join us from Emerge, and we're going to be having people joining us from like GI. And like, I think we're very happy to have people who have nursing experience, and we're always like, at least at Sinai, I can only speak for the team at Sinai, but we're just so happy to have people who coming from other units. It really like broadens our scope, especially with the high risk patients. And I think Kyla had asked a question about like, what is a high risk patient? So maybe I could answer that. And I think it just ties into the discussion about having a nurse come from another specialty area. So when we talk about high risk patients, we mean patients who have some other type of medical condition and they are also pregnant. So they may have gestational based issues, like if they had a gestational hypertension that's caused by pregnancy, or they may have gestational diabetes caused by pregnancy, but they may also have a chronic hypertension or type 1 diabetes. Maybe they're in diabetic ketoacidosis. We have a huge population of patients who have cardiac issues. So if you come from a cardiac floor, yay, even though we're not officially trained to read the ECGs, we will love to have a cardiac nurse on our unit for sure, because we have lots of very high risk cardiac issues with our patients. We have had paraplegic patients deliver, which is a high risk issue because they often don't have the sensations that everyone else does when they're having a birth. What else can I think of? We have had very odd, strange endocrine disorders that are, rare. And then also, of course, all of the extremely premature patients who are having deliveries at 24 weeks, 23 weeks even. A high risk nurse would be taking care of them. Maybe if they had broken their waters and we're trying not to deliver the baby, or we are managing the delivery of the baby. So I think maybe that's an example of high risk obstetrics nursing.
And there's also the high risk from the fetal side as well, which I'm sure Melina can go into a little bit more. But if you have twins, triplets, quads, if you have something wrong with your actual pregnancy, so I could be a healthy woman, but when I get pregnant, maybe there's something wrong with my placenta, or there's something wrong with my amniotic fluid that makes my pregnancy more high risk, or I need to be on bed rest. Those type of patients we'd see there. And then also different babies who have diagnosis. Maybe the baby is going to be palliative when it's born. It's going to be born with a condition that's not sustainable for life. Or maybe that baby has a cardiac condition where as soon as they're born, they need to be rushed right over to sick kids for surgery, or they're born with their organs outside of their body in a condition like gastroschisis or omphalocele, for example. So there's so many things that can happen in utero. So when we talk about high risk patients, it can be because the baby's high risk, or it can be because the mom's high risk, or it can sometimes be both. And there's so many different things. Melina can probably speak to a bit more of those fetal conditions that we have. But it's very interesting. And oftentimes you'll get this patient with this condition that you've maybe never heard of, or it's a first, and that's kind of what keeps it so exciting.
Perfect. I will go through a few more questions, and then there are some topics I wanted everyone to touch upon, because I think a lot of the times people think about L&D and birthing and really kind of focus on those kind of topics and the trajectories of the happy deliveries and even labor and complications, but we will talk about some other topics after. Next, we have a question from Melanie. What does the typical day look like in L&D, and what types of things are nurses responsible for?
Okay, I can I'll take this one. Okay, so a typical day, you have your patient. For us, we self-assign ourselves, so that gives a good way to change up your assignment day to day, but other units, you might be assigned your patient. So let's just say we have a low-risk laboring patient. You're going into the room, you're responsible for keeping an eye on the fetal heart rate, which could be continuous, or it could be that you're listening here and there every half an hour, every 15 minutes, or sooner if they're pushing. You're in charge of all the medications that the mom has. So the IV, making sure that you're assessing the IV, that it's not gone interstitial, that it's working properly, that it's not hurting the patient. You're assessing their bladder. You're basically doing that head to toe pretty much, except might be a bit more specifically tailored to like maternal fetal unit. You're in charge of answering all the patient's questions and putting all their worries kind of at bay and helping them know the plan. For us, if they're on an epidural, in charge of looking at, is the epidural working properly? Is it managing the patient's pain? And if not, where to go with that and who to call. And then also just their labor. So changing their position, doing internal exams to see that they're dilating, running oxytocin medication, which helps to increase the contraction frequency and strength to make sure their labor kind of goes on cue. And overall, helping just to have a safe birth. So we're also there when the patient's pushing, when the baby's out, and when the baby's out, then we're there for the postpartum. So making sure baby's transitioning well, making sure mom's bleeding is stable, and then eventually transferring them to a postpartum unit where they would stay for 24, 48, sometimes even longer if there was an issue. So we're there with the patient through the whole thing, through the whole from start to end with their birth.
Perfect. Next, we have a question from Manahal. What would you recommend for a nursing student who is interested in L&D? So I think we briefly covered that, but I wonder if anyone else has anything else to add to that question.
I would say just take those different certifications. That'll give you kind of an idea as to whether or not you're interested and you're really engaged in what you're learning. If you take fetal health surveillance course and you realize, I'm not really into this, then maybe labor and delivery is not for you, because we have to do that with every single patient. But yes, take different courses. The more you can educate yourself, you're going to get your foot in the door and you're going to get that interview. And then once you have that interview, if you're able to, prove that you have that passion and that commitment to labor and delivery nursing, then that's what you need, is just those certifications to get your resume through the door. And then the rest is up to you to kind of show how passionate you are. And we don't always pick people who have, the biggest resume, the most experience. There are a lot of new grads who do work in labor and delivery, especially in recent years where we've had a lot of nurses retire. A lot of nurses that we have are with under 2 years of experience, even under 1 year of experience. So if you had that commitment and that passion, that dedication, we can sense it. And that's kind of what you need, other than those basic certifications. And then the rest we can teach you.
Perfect. Exactly. Just adding to that, definitely getting yourself involved. So being involved in organizations like CAPWIN or like our Maternal Child Nurses Interest Group. So really making those connections and networking in that way so that you can really have a sense of, what L&D nursing or obstetrical nursing is like. And you can really stay up to date, even joining webinars and conferences. All of that will add to your learning and understanding and will look good. And you can speak to those things because you're really putting your time and effort into this area and exploring it more to make sure you have your own base and understanding and connections to that.
I wanted to add one thing to what Melina was saying too. That is kind of like a day in the life of an L&D nurse, but not to forget that can be our ideal. You could also be then running to scrub for an emergency C-section, or someone's been brought in fully dilated and is delivering, and then someone calls a code pink down the hall on the baby. So high-risk obstetrics has that lovely one-to-one nursing where you're often assigned just one patient and you really get to build that relationship. But you are also always on your toes and you're ready to jump in 100 different directions. And in one day, I could have 2 vaginal deliveries, I could scrub for a C-section, then I could admit an antepartum patient who needs special one-to-one care. So every day is different. You never really know what's going to happen when you come to work that day. But that's part of the great thing of it.
Awesome. So we don't have any further questions right now, but please continue to type them in the chat. Some topics I wanted to gauge our speakers to speak about a little more is maybe our perinatal loss population, whether it be maternal or fetal. So if anyone wants to speak to that.
Yeah, sorry, Emily, the question was about perinatal loss and what it's like to work with perinatal loss patients.
So caring for this population and recognizing that that is a huge side of obstetrical and perinatal nursing.
Yeah, I guess a couple of us kind of gestured to the sadder side of obstetrics nursing. And I think that's definitely something that's unique maybe to Sinai, that we have quite a few terminations of pregnancy throughout the year, whether the patient is terminating. I guess a lot of the terminations that take place before 20 weeks would happen on the antenatal unit, and usually it's for some type of genetic abnormality or condition that's not compatible with life. And these terminations go through the TOPAG, which is the committee that decides whether or not it is ethical to terminate the pregnancy. And then in labor and delivery, we work with patients over 20 weeks who are having a termination, also for a genetic condition, but we work with them and we're able to provide them with better pain management, such as epidurals over on the L&D side. Also, with the larger gestation, the birth is a little more difficult, potentially. We also work with patients who've had an intrauterine fetal demise where the baby has passed away, and potentially at a higher gestation, and we need epidural and we need to push with the patient and deliver the baby there. So working with patients like that who have experienced a loss and will deliver a stillborn child. We have a lot of resources for the bereavement patients. We have an excellent bereavement committee that helps stock and organize our bereavement room, where we will wash the baby and dress the baby. We take photos of the baby as mementos for the parents. We will provide little bracelets with their names that we make for the babies who have passed away. We have many resources we provide the parents, including information, websites, and community help for grieving parents and how to go through this loss, how to organize funeral arrangements for babies over 20 weeks, because that is an Ontario requirement. We also provide them with information like the weight of the baby, and basically just provide what we call a memory package. I think also the perinatal, it's the PALE network that I think we have a couple of brochures from the PALE network through Sunnybrook as well that we provide to patients. Basically, we give them a whole package when they deliver if the baby has passed away. So there's lots of that happens at Sinai for sure.
And you've received training for this. It's not that you're expected as a new labor and delivery nurse to be, okay, you've been here for 6 months, like now go take this full-term IUFD, intrauterine fetal demise, by yourself. It's always, a team effort, and there is specific training for how to care for patients and their families culturally, in a culturally sensitive way, and the way to communicate with families in the way of making these care packages, and how to kind of deal with the various types of losses, either under 20 weeks, over 20 weeks, depending on the weight of the baby, depending on the type of perinatal loss. So there is lots of training that goes into this as well. And that's kind of another really great part about high-risk nursing. It is very happy 90%, 95% of the time, but there is naturally loss. 1 in 5 women do experience a pregnancy loss. And if it happens to be, close to 20 weeks or close to full term, then they do come to our unit. And that's part of our job as well.
And sorry, just to add to that as well. So I was actually going to speak about this, but someone just asked, is there support for RNs to deal with the losses? So for me specifically, I'm a pretty happy-go-lucky person. So for me, that was like a huge like caring for patients with losses, I felt like a huge burden personally from it, because can be so emotional and so sad that you're just there in, like, your unit has someone going through the best day of their life, that they've waited for this baby for 9 months, and someone having the worst day of their life, that their baby is no longer there. And I really struggled with that. And I had an experience where I had a friend who lost her baby and I was there for her. And then I just had a few kind of in a row, and I felt very, very heavy, very, very unlike myself. Just not like, I could tell that like my mental health was really not doing well. So at Sinai, we have actually like a psychiatrist that is in charge of just making sure that specifically in L&D that we're doing well. So they come and they do check-ins with us every few weeks. They're always available on email. So I actually ended up going to see her for a few sessions just to talk about what I was going through, because I just felt so heavy after just being there for these patients. And for me, it was also seeing my friend go through it, someone that was very close to me, and being involved with her care and the memory package and all that, but then just seeing that, you know, how it affected her and being there for her, and then having other patients, I just felt very, very heavy and sad. And I carried it with me home, which is a way to kind of know that you need help when you can't really stop. You can't separate it. You just carry it with you the whole time, and in an unhealthy way. Because of course, all our patients, we kind of carry them with us and the experiences we have. But when it becomes overwhelming, and when you can't go back to work, or when you're just feeling so down about it and it's affecting your life, then you definitely need help. So there's lots of resources. There's also a phone number that we have that you can call. I'm not sure, Marley, if you guys have the similar experience at your hospital, what resources you guys have, but they're definitely out there. Sometimes you have to seek them out. They're not going to necessarily come straight, you know, to you and make sure, hey, how are you doing? Some colleagues will do that. A lot of them will just say, hey, I see your assignment today. Like, just wanted to check in with you to see how you're doing. But sometimes you just have to take the step, speak to your manager, speak to your colleagues, see what resources are available to get the help you need. And there's nothing like, it's heavy. It's a lot of, our job is really intense, and we're really in the thick of it with patients some days, and really there for them. And sometimes you cry with them, and that's okay. And sometimes you don't know what to say, and that's okay. And you have to make sure you take care of yourself, because if you don't, then you're not really going to be the best at your job. You need to really take care of yourself to be the best nurse that you can be, and to provide the best care that you can. So there's definitely stuff out there.
Okay, I can just add my perspective from working at MAC. So we still do a lot of terminations as well. Sometimes they'll go to Sinai first and get a KCL injection for baby, and then they'll come to us if they're one of our patients for the termination and that care. And we also see IUFDs, of course, at MAC. We don't have like a particular psychiatrist, I would say, that works with our unit, but there's ones within the hospital that kind of care for all different units. So that's definitely a resource we have. Again, just with our increasing numbers we've had over the last year, staff has really noticed an increase in the amount of terminations and IUFDs that we've had. I don't know if that's something you guys have experienced as well, but so we're all kind of feeling like a little bit burnt out. So this is like nursing welfare is something we've been kind of talking about and thinking of ways that we can better care for ourselves so that we can care for our patients. So I think it's something that we just really need to work on and do a better job of. We don't assign ourselves like you guys had mentioned you do at Mount Sinai. So the charge nurses will assign us our patients for the day, but we do have like a list we keep track of who's cared for a stillbirth and the dates of that, so that it's not kind of back to back, that everyone's taking their turn. But regardless, it's always emotional and it's draining and it sucks, but it's also, you do feel a very special bond with those families, and it is rewarding in that sense. But yeah, I mean, they suck and they're sad, but it's unfortunately a part of the job and a special moment that we can share with those families and try and make it as best of a experience for them as we can.
And to add to that too, Marley, with my friend that experienced her loss, like the memory package, those photos, the care that she had, it was like, that was like 3 years ago. And for her, she still has those photos of her son. She still takes out the memory package. She still, like, she looks back and she felt so cared for. And I think that is what pushes us in those experiences when we're having that like tough time caring for these patients. You just have to remember that you're really, really like impacting their life and going, like helping them get through presumably one of the worst days like ever that they've ever experienced. So from experience from her and talking to her, I know that it definitely is very like helpful and rewarding. And like those pictures, that Mary package just, it means so much to her, even 3 years later.
Amazing. Yeah, so as Chelsea was mentioning, the PALE network is a pregnancy and infant loss network. And basically a lot of parents who have experienced losses will connect through that group, also almost like a little network of parents understanding and going through similar things. So they have a place to vent and have a network to feel belong to. So that's a really great resource that we always give to our patients. Another topic I wanted to touch base on was kind of all the crazy procedures and surgical things that we do, such as like Perinatal cases, invasive placentas, delivering off service. So we will have patients like in CCU, in ICU, at Toronto General, etc., at Princess Margaret even. If anyone wants to speak to those kind of special off-service patients or deliveries and things like that.
I guess I'll take this one. Okay. So yes, at Sinai, we do crazy things. So procretas basically are just the placenta's kind of invaded beyond where it needs to invade. So it doesn't, after a delivery, the placenta should just kind of come out all in one piece. But when you have a procreta, it's actually like embedded into the uterus and sometimes even into the bladder. So these cases, the patients will see like a CNS beforehand. They have a huge care plan. We deliver them in the main operating room. And there is a main operating room nurse and circulating nurse that that are there for the birth, plus an L&D nurse and like a respiratory therapist who is there for the baby. And also to take care of the mom postpartum. So we do a lot of post-op work with those patients, the procretas. We also do, I don't know, Emily, do you want me to talk about OFC or should I save that for later?
Yeah,
so the Ontario Fetal Center, it's the only one in Canada. It's kind of where my home is, I feel like these days. So basically one of our main surgeries that we do is to fix spina bifida in utero. So it's very cool. It's very innovative surgery. So spina bifida, for those of you that don't know, so basically babies have like a lesion or like a hole at the bottom of their spine. So all the nerve fibers that are in your spine, as they go through the pregnancy, they kind of get damaged because they're hitting all sorts of things in the uterus. Once those babies are born, usually they would go to sick kids for surgery where they would just patch that up. A lot of these kids have mobility problems, incontinence problems. They need brain shunts from this condition. So the thought was, if we could close this hole in the baby's spine in utero and keep the mom pregnant, it would basically preserve all those nerve fibers so they wouldn't be damaged. And that's exactly what we do. So we go in, we make an incision in the mom's tummy. We literally take the uterus pretty much out and the baby's inside. We ultrasound the baby's heart, the whole surgery, to make sure the baby's doing well. We give the baby some meds, like the fetus, some meds to just keep it still. And then we make a hole in the uterus, and the hole about this big, basically you'll see the lesion of the baby's back that's opened through this hole of the uterus. Then sick kids comes in, they sew it all back together. So everything's nice and closed. We close the uterus, we put the uterus in, and we cross our fingers that the mom stays pregnant close to her due date. And these patients stay with us for like 3-4 days in L&D because they need pretty extensive monitoring. We have to make sure they're eating and drinking and moving, that their pain's under control, that they don't go into labor. And then they'll go to the antenatal unit where they'll stay for a few days as well to get scans. So that's a huge program that we have at Sinai that I've been involved in and loved being with the patients. And then also loved seeing the kids come back just like as an update, and they're walking and they're running and doing so well. So it's been so incredibly rewarding. And we also are just starting a new program because there was a huge study about congenital diaphragmatic hernias. So basically where kind of organs and everything are kind of coming up through a hole in the diaphragm, and then the lungs get squished of the baby. So what we do is we go in with a camera into the uterus, we put a tiny balloon like right about here and lock in the amniotic fluid in the lungs so the lungs stay expanded, and that helps the lungs develop and it helps push all those organs kind of away. And then once the patient's about 35 or so weeks, we go in with the camera, we take the little balloon out, and then moms can deliver and babies can go to sick kids after for care. And the study that they did basically showed that there was great outcomes for these kids and great improvements of their quality of life with this procedure. So we've already seen a bunch, but they've kind of prepped us that a whole bunch more will be coming. And because of COVID, the last kind of thing I'll point out is that we have done some deliveries in ICU because moms have been too unstable. So at Sinai, there was a period of time where we had about like 50% of our ICU were pregnant women who required a lot of care. And we've kind of developed how to take care of them because we've never been in this situation. We don't know how to take care of pregnant COVID patients because we never had this before. So we've kind of developed a whole system, and those patients have had literally C-sections up in ICU on their ICU bed. And our role has just been to go there, do the same thing, scrub and circulate, work with the ICU team, work with their nurses, and work with our pediatric team as well, our respiratory therapists, peds fellow, residents, all the people, and bring everything to the patient in the ICU, and then deliver them there. And that goes the same if we have patients at Toronto General or if we have patients at Sick Kids. We bring all our stuff and us all over to them, and that's all organized by usually our clinical or our coordinator, who just kind of organizes where everybody's going to be, and then we just go with the flow.
Yeah, I think just building off of what Melina said, high-risk obstetrics is such an innovative area. It's really amazing and exciting, even over the last 5 years, we've just seen these things that physicians and nurses are capable of doing together. There's a couple of other things that we've done as well. So we do sometimes it's something called an exit procedure. So if the baby has some type of abnormality with their mouth, or there might be something blocking their airway, for example, as soon as that baby is delivered, we have a sick kids team who's standing right there, between mom's legs, ready to intubate this baby, so that before they cut the cord, then we can actually establish an airway for this baby, and then they can go and perform surgery to remove this or fix whatever it might be. Or there's a lot of high risk multiple pregnancies also that we see where they can go in with actually like a laser while the mom is pregnant and kind of divert some of the venous flow and arterial flow on the placenta to help redistribute the blood equally between the 2 or 3 babies. So pretty amazing that otherwise without these type of technologies, these babies, or at least one of them, likely wouldn't survive. But when they're able to go in and sometimes redivert the blood, then both babies are able to grow a little bit more equally and they have a better chance at survival, which once again wasn't done until recent years. So pretty amazing. You never know what's going to come next or what rare conditions going to present, and that's part of the great part of high-risk labor and delivery. I think it's just so exciting and it's so amazing to be involved in such a team atmosphere. You can stick your head out of your door and you're going to see like 5 of your colleagues. And if you ever need help, like everyone's there to help you. And it's really about accomplishing these things as a team and having that patient as part of your team as well. Because ultimately we want a healthy mom and we want a healthy baby. And we want to give them the best experience as possible as their nurse.
Perfect. Just to add to those points, thank you, Melina and Brooke, so much. We at Sinai, we do have a procedure room where some of the nurses are trained in sonography. So there will be the ones also completing obstetrical ultrasounds and assisting with some of these crazy procedures that might happen, and assisting physicians with these procedures with the ultrasound guidance and things like that. So that's another realm of nursing that you might never have think would be possible, but anything is possible in obstetrics for sure. Let me see, I don't think we have any more questions. So if everyone has any parting sentiments that they would like to say to our guests today.
I have one thing to say. If anyone is interested in working up north, there is a dire need for obstetrics trained nurses. And it is the most amazing, amazing, eye-opening, heartwarming experience. And it is so different than the care you see in downtown Toronto or in Ontario in general. So if you have a nick for traveling and you kind of want to explore what else is outside the walls of Ontario, there is some amazing hospitals and communities who would love to have expertise of high-risk obstetrics nurses. So it is so exciting. And that's kind of part of high-risk nursing in the sense of you have to have enough competence and enough experience to feel confident in your skill. So at least usually 2 years of nursing, obstetrics nursing, but I can't speak highly enough about taking the dive and going for it. I went by myself, and there is a lot of funding for, like, they pay for your hotel and your flights and everything like that, but went there knowing nobody and have made some amazing friends and have like memories that will last forever. So that's another part of high-risk nursing, is going rural. Same in rural Ontario as well. But if anyone ever has any questions, feel free to reach out, but definitely go for it if you have the chance.
Amazing. I did miss one question from Sarah. How many patients are usually in L&D units? Or maybe we could talk about the staffing and the patient ratio.
Sure, I can take that one. So we hope that L&D nursing is one-to-one care, especially for high-risk patients, one nurse to one patient. We have been surging recently, just like Marley said, at Sinai. It has been very busy in the last few months. So you may be doubled up to hopefully a maximum of 2 patients at a time. And usually it would be patients that have delivered and not transferred to the postpartum unit just yet. So you may have 2 postpartum patients, or you might take 2 induction patients that are in very early labor. We have about 24 nurses that work on the day shift, 3 of which would be, 4 would be in the operating room, 2 in the triage department, 1 charge nurse, and the rest of them on the floor. And then on OFC days, there would be 2 or 3 nurses in OFC. So there are a lot of staff, but there's also a lot of things to be done for the day. We have maybe between 6 to 9 inductions for the day, like 5 booked C-sections for the day, plus all the laboring patients that are coming in through triage, and the high-risk patients that are being transferred through the critical program, either to Mount Sinai or to Sunnybrook, depending on whether or not we are on intake that day, which we kind of go back and forth between Sunnybrook and Mount Sinai. So it is an extremely busy place. So 24 is kind of the minimum staff that we would have on during the day. And then we hope that we have 20 nurses on the night shift and 18 nurses on the night shift during the weekends. But like any other hospital area, we are short pretty frequently. We do try and replace, but during COVID, it has been a bit of a struggle for sure, especially people who are off because they've got a COVID swab or are just generally off sick. So yeah, that's essentially the staffing.
We must have one of the biggest units probably in the province, or maybe even the country, downtown. I think most community hospitals only have about 10 nurses on. And then 2 of those are triage, 2 of those are OR, 1's a charge nurse. So that's kind of what I have in community hospital here. And then same kind of thing, like when you ask how many patients and how many nurses, it just depends on the day. You can come on a day like today where I come in and there's 2 patients in labor, or like yesterday where there's 10 in labor and you are doubled up and you're just trying to get by. So there's a lot of ups and downs in labor and delivery, where sometimes, you're having kind of an easier day, or you're able to help out and able to be there and doing things 2 to 1 almost. And then you have some days where you are running around nonstop and you might have 2 patients. So you just never really know. There's probably no easy answer to that, but yeah, that's my answer.
Yeah, you're right. I am talking very Sinai specific because we have 5 operating rooms, 19 labor rooms. We have 8 post-anesthetic care unit beds. We have 8 triage beds. We have another 6 obstetrical day unit beds. I mean, we have our census in L&D is usually like not excluding triage, we have 12 to 15 patients in our labor unit at a time. And then triage can have anywhere between 5 to 25 patients. So we can be extremely busy. Sometimes, some days between triage and the L&D unit, we have up to 30 or 35 patients with only 24 nurses on the floor. And those are the days that are really crazy. And then some day, like last week, I walked in and there was 3 patients on the board, which was a bit of a unicorn day. But, you know, it is very unusual. You have to be adaptable. Like my sentiment for the nursing students out there, if you want to choose labor and delivery, roll with the punches. You have to be able to roll with it. It is an area you have to be adaptable. You have to jump in. You have to help. You have to be ready to, you know, jump up at any moment and do something that scares you, do something that's new.
You guys are like, you have a huge unit. Got 8 birthing beds, 5 beds in triage, 2 ORs, and 2 PACU beds. So we're usually 10 nurses during day shift, 1 being charge, 1 in triage, and then 3 in OR. We usually have 4 or 5 booked inductions and 3 or 4 sections booked. So we need more beds, but that's okay. And usually 9 nurses at night, but the same thing. We try and be 1-to-1, especially in active labor, high risk, but it's not always possible lately, but we'll see. Maybe it's just all COVID babies, or I don't know.
We have a question from Sarah. In general, in L&D, how personalized can the care you give to your patients be? Are you able to encourage mothers with different positions or pain management strategies outside of medication?
1000%, that would be my response. Please do. We want the most individualized, specialized, personalized care that you can provide. It's really frowned upon when you put your patient on the monitor and spend all your time at the nursing station. Be at the bedside. Encourage them. Like, honestly, you're the person, a lot of them don't have experience. So you're like, let's try this ball. Let's try this position. Let's get you in this position. Let's try the shower. Let's try, the birthing tub. Let's use a squatting bar. There's all these different techniques. And unfortunately, with high risk labor and delivery, we do see a lot of patients who have an epidural for different reasons. So they are on the bed and there aren't a whole lot of things that you can change, but that doesn't mean you can't provide them with different encouragement when it comes time to pushing. And then if you do have an unmedicated patient, you kind of spend a lot of the time at the bedside, and it's using your imagination and thinking what's going to be best for your patient and that baby inside their belly, depending on what the situation is. And so when I was up north, for the 2 months I was there, I had 2 epidurals the entire time. So every single patient was unmedicated. And that's kind of what I loved, because you have to be able to be just constantly changing things and really providing the individualized care. So that's definitely a big part of nursing is taking it how you want. And different nurses are very different, but we definitely 1000% encourage that.
Amazing. So I believe that's all the questions from our participants today. Again, I thank all of you for taking the time to attending today's webinar. We really appreciate your attendance today. Thank you to our 4 lovely guest speakers. We are so blessed to have understood the expertise of L&D nursing and high-risk birthing and all the opportunities that come with. I hope everyone was able to learn something new today and have a takeaway, and hopefully this will encourage all of you to explore your passions and really fight for your passions. Again, this webinar is recorded, so please check it out on www.mcnig.ca. Follow us on Instagram at MCNIG.RNAO and Facebook at MattChildNursesIG. If you have any questions or would like to get into contact with any of our speakers today, feel free to email us at mcnig.rnao@gmail.com. Again, thank you everyone for attending, and I hope everyone has a lovely weekend. Take care and stay safe.